So thank you everyone for coming to Ping Pong Parkinson's first speaker series, where we will be covering different aspects of how to navigate Parkinson's care. And for our first speaker, we have Dr. Jeff Bronstein. Dr. Bronstein is the director of the Movement Disorder Program at the David Geffen School of Medicine and professor of neurology at UCLA. And in his talk, he'll be going over surgical management of Parkinson's using techniques such as deep brain stimulation or stem cell transplantation. And I'll let Dr. Bronstein take it from here.
All right, let me share and we'll get started. So there's going to be time for questions at the end. Sorry, I just need to move things around a little bit. I can see. All right. Um, and my talk's a little bit long. Do you see my presenter or are you seeing the regular slides?
I can see your regular slides.
So you're not seeing presenter mode.
No.
Perfect. Okay. So, advance here. So the whole idea of Parkinson's surgical treatments basically is to balance the circuitry that's within the basal ganglion. Um, and we do this in a variety of ways. So this is kind of a schematic of the circuitry. And so normally, sorry, um, so we have the substantia nigra is here, and it releases dopamine in the putamen, and then it either goes through the direct pathway or the indirect pathway. And when you lose the dopamine cells shown here on the right, what happens is the direct pathway becomes underactive and the indirect pathway becomes overactive. And it's the imbalance that's the problem. So, what we do with surgical treatments, not counting stem cells, so we'll talk about stem cells separately, but is to reduce the overactivity of the indirect pathway because it's a lot harder to increase the activity of the direct pathway. So it's the balance, relative balance that's important. The other way to do it is replace the dopamine in the putamen, which is where what we are attempting to do with stem cells. So the basic concept of surgical treatments are really, patient selection, um, targeting, like, where you put the electrodes and how good you are at hitting the right spots, and then programming when it comes to DBS. So, a couple of the important basics that it only responds to symptoms that respond to levodopa. So, if you have rigidity and the levodopa helps, it works for that. If you have balance problems that even when your meds are working great, and I give you a little tug from behind, you're going to fall over, DBS won't do anything for that. So if you think about your best on time, it gives you more of that. Now, with that said, it can take care of some tremors that don't respond to levodopa, and it can help dyskinesias. So those are the only qualifiers that I'd put there. Now, when it comes to targeting, the thalamus only treats tremors. So it's important to, if we're going to make a lesion in the thalamus, we're going to put a DBS electrode. It only treats tremors. It doesn't treat other symptoms. So we rarely do that for people with Parkinson's. We usually go to either the STN, the subthalamic nucleus, or the GPI to treat the motor fluctuations. And they also get tremor as well, but not quite as good as the thalamus. It does not alter disease progression. It doesn't slow it down. It doesn't speed it up. It does nothing for progression. And again, you get more of your good on time with less dyskinesias. So there's been a variety of studies over the years, and you can look at the dates. So DBS was approved for tremors in 1998. So we've been doing this for a long time now, and it's changed some, but not as much as you would think. Anyway, this is a study that I was part of. It was a VA NINDS trial. that we published the first report looking at deep brain stimulation. And was it better than just giving medications? And the answer is yes. People that were getting DBS did better than what we call best medical management. Things have changed a little bit. We now have VLEV, which may approach it. So best medical management has improved since 2009, but DBS still offers many advantages over medication. So then the question is where to put the electrode. So when we started with all of this in early 2000s, we really tested whether GPI or palatal stimulation was as good or better than subthalamic or STN. And at the time, everybody believed STN was better. Um, sorry. STN was better, but this was a double blinded trial. So, we had unblinded and blinded people. So I was unblinded for many of them, from all of the ones at UCLA and at the VA. And it turned out that STN and GPI were equally as effective in controlling motor symptoms. STN, you could reduce the medication more than you can with GPI. The numbers in general are usually about 50% reduction in STN and about 20% in GPI. So if reducing medicines is your goal, STN is better. STN was associated with worsening depression, executive dysfunction, had some behavioral issues that did not occur with GPI. And there was more falling in the STN group compared to GPI. And most of us believe that was really due to this executive dysfunction. People were, a little bit more impulsive, would pop out of the chair faster, that sort of thing. Things have improved a bit since then with steering, which I'll talk about in a minute, but these were the results of that trial. There were several other trials also looking at comparison of GPI and STN. And in general, they're almost identical in the benefits, except for the changes in medication. GPI actually tends to be a little better for dyskinesias in most studies, including ours, though the significance was borderline. But in general, people have more dyskinesia that have a lot of dyskinesias tend to do a little better with GPI. Uh, Complications. So strokes, hemorrhage or stroke are about 1%. Um, each center is a little different. People generally recover most of the ways from that. Um, Infections, that has come way down over the years. It was about 8% when we did the study. It's down to 2 to 4%, depending on who does the counting and how many years you go back. And stimulation side effects are common, but they can be that it's manageable because we can adjust simulation so they don't have to be there and they're transient, which is one of the nice things about DBS. So this is hardware. It keeps changing. This is Medtronics. We now have three different companies. We use all three. Medtronic. They each have their own, added feature. Medtronic's added feature now is adaptive DBS, and I'll talk about that in a few minutes, where it responds to the brain activity and adjusts itself automatically. The Abbott system, you can do programming over the internet. And then Boston Scientific has some very special type of leads that allows for some very complicated programming, as well as some technology that assists in helping you locate the best leads to program. So they all have their pros and cons, and each surgeon has their preferences as well. We tend to tailor it to what's best for the patient. So the newest things, not so new anymore, is these segmented leads. So they're broken up some of them are broken up into different segments, and so we can steer the current in different directions, and so then we can avoid some of the side effects. So there are many side effects you can get when you stimulate the wrong place. So if the electrode's in a good place, but maybe just a little bit off to the right, you can then steer the current to avoid getting side effects. Um, we now have rechargeables. In fact, they're very good, and all three companies have rechargeables. They're a little bit smaller, which is really nice for people. They have a lower profile when implanted, so people are using those more and more. They're MRI compatible. The programming has become easier with our programming devices. We can now do it over the internet with the Abbott. And we have a better understanding of the side effects, the risks, etc. So this is the first directional lead that came out. Now it's a little bit old. This is the Abbott, and you can see the segments here. And so we can activate any or all of them so that the current is directed where we want it to be. So we get the best effect with the least amount of side effects. And this is just a schematic of where we put these. Um, so this is the STN is down here. Deep, the GPI is right here, globus pallidus interna, and you really can't see the thalamus very well in this picture. Um, and that's where we target them. This is how we do it at UCLA. There are different ways of targeting. Now, this is the traditional way with a Lexel frame. We wake people up in the middle of surgery, but we put this on early in the morning, and then we use brain mapping. So it used to be all done by measuring. Now with the MRIs are so good, you can measure, from different landmarks in the brain and then make adjustments based on that person's individual anatomy. And you can see the different nuclei now. And at least here at UCLA, misplacement electrode hasn't happened in a very, very long time. We've really gotten very good at targeting. This is what the operating room looks like. We actually use a C-arm just so we make sure when the electrode is secured, it doesn't move at all. And then we do intraoperative recordings. This is actually a really old one, but it's still the same. So as we poke through the brain and move down slowly, we get different recordings. And so we know where we are. So this is when all of a sudden you start to hear it, we can actually hear this. So this is kind of the slow kind of tap, 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 irregular that we hear in the thalamus. And then when we transition into the GPI, which I actually didn't show here, it looks a little bit like this, but a little bit faster. And then when you hit STN, it really gets going, and you can see lots of single units or double units. And then when you hit the Nigra, when you go a little bit too deep, you hear this very, very regular pattern. So we know where we are. When we started doing this, we actually did many passes to map out the whole area, but now we're pretty good at just knowing that if we get about 5 millimeters of good STN, for example, we know we're in the belly, right where we want to be. And then we do stimulations while we're in the OR, so that we can make sure that the person doesn't get side effects and we see benefit on the table. And if we see side effects at low voltages or low currents, then we know we have to move it. And again, when I said we have a better understanding, our understanding now tells us when you have a certain type of side effect, we know whether we have to move anterior, posterior, or laterally or medially based on the side effects. So this is what's called adaptive DVS. This is the most the newest thing we have. It's only available through Medtronic. One of the things that's really nice about it is it's good for research as well. So we're doing a lot of research Because now what it does is we put the electrodes in and you record from those electrodes as well as stimulate. And what we're recording are what are called local field potentials, LFPs. And these LFPs, it turns out, um, represent uh, some of the Parkinsonian symptoms. So these are called beta waves here, based on the frequency of these local field potentials. And then what we do when we program is we can set uh, thresholds, either when they're too low or too high, and what happens is they sense these LFPs, and when they get too low or too high, they stimulate uh, the brain, and so the stimulation only occurs when you need it. And so the question is, how much does it help? So it turns out that for most people, it doesn't make that much of a difference, continuous stimulation versus adaptive. But there are people that have um, uh, that it's really difficult to program, and it really can be very helpful to use adaptive. So that's why we tend to, if there's no other preferences, we tend to use more Medtronic now, just because if it's a tough patient to control, say, tremor, we use these LFPs and they're very helpful for those individuals. And you can see if you look at yeah, adaptive. So we'll look at the dual threshold, which is what we use most of the time. You can see that most of the people are doing a little bit better than they were before. And the dark circles tell you that they chose to stay on adaptive versus continuous. So more people tended to want the stay on the adaptive versus the continuous stimulation. And you can see that you have a little bit less off time compared to continuous, a little bit good on time without disabling dyskinesias. So there's some benefits, and the benefits can be large on individuals, but not everybody really needs to go adaptive. So who are the best candidates for DBS? So you can think of people that have, you have to have motor fluctuations, at least most people's centers, and that they start becoming a problem. They're starting to interfere with your quality of life despite best medical management. Most insurance companies require you see at least a 33% improvement in UPDRS when you give levodopa from an off to an on state. And that's just kind of a quantitative way to say they have to have a good response to levodopa. Younger people tend to have the better responses, but they tend to have the bigger motor fluctuations. So there's no age limit. It's really the motor fluctuations and the size of those fluctuations that determine who are going to be the best candidates. Now, it doesn't change your cognitive abilities, but if people have some dementia or some significant cognitive problems, it doesn't necessarily make it worse. Obviously, any surgery can cause some confusion, but that becomes the most disabling factor. So we tend to avoid operating on people with significant cognitive problems for that reason. We also want to make sure people have treated their depression ahead of time, since stimulation, especially in the STN, has been associated with depression. And for the same reason that we don't like to operate on people with cognitive impairments, we don't like to operate on people that have hallucinations. And they need a support system, especially perioperatively. And probably most importantly, they need to have realistic expectations. This is not a cure. It's not going to stop your disease from progressing. It's just treating the symptoms. So when to operate, this is a matter of huge discussions. Um, you look at the pros and you look at the cons. The insurance companies want to see people have it for at least 5 years. And I think that's a good rule, mostly because there are atypical Parkinson syndromes like MSA, multiple system atrophy, for example, that sometimes look like Parkinson's early on, but by 5 years, you figured it out one way or the other, and they don't respond well to surgery. So it's mostly to make sure you're dealing with somebody with Parkinson's disease. Most people don't get significant fluctuations in under 5 years anyway, so it's usually not much of an issue. Um, the best people, the pros of going early, people tolerate the surgery well. The disease hasn't destroyed your life, and I'll come back to that in a second. It also allows for less medications. The cons are it's brain surgery. It's expensive. Um, there's maintenance that goes along with it. Um, and if you wait, new technology is coming out. So better stimulators, um, etc. Also, you're not available for other clinical trials, and theoretically could interfere with future therapies. Um, One of the earliest studies done by health services here at UCLA was done with epilepsy, and it was really useful. Is what they found is if they took somebody with intractable seizures, medicines couldn't control it, and they had these for 20 years, getting rid of those seizures by doing surgery did not change their quality of life significantly. It was only if you interfered early on, before they lost their job, before they lost their normal quality of life, then it had a huge benefit. And that's the way I think about it for DBS. It's a lot easier to keep a job than it is to get a new one. So if you're having problems working because the fluctuations are getting there, I'd rather operate on you early so you don't lose your job, as opposed to waiting till you lose your job and then trying to find one is a lot more difficult. There are a few centers that like to operate very early, um, and people do well, but people do well with medications as well. So um, it's a bit of a discussion you need to have with your doctor. So I'm going to switch now. And again, I'm sorry for I'm going so fast, but I want to get through a lot of this. So focus ultrasound is really important. It's a lesion. So we burn a little hole. We used to call them thalamotomies and pallidotomies when we used to do it with under surgery, putting an electrode and then heating it up. Now we do it in the MRI scanner. So it doesn't require surgery. It uses ultrasound, and it has many different ultrasound portals that center on one little spot, and in this case, the thalamus. But you can do it in the pallidum now. It's approved. Um, it's a lesion. You once you have it, you have it. So it's great when it works, but there's a fairly high rate of side effects with thalamus. About 25% will have transient neurologic problems. Most of them get better. You don't have any hardware, so it's nice. You don't have to open the skull, which is nice. But you have the risk of getting some permanent neurologic injury, and it's non-adjustable. So Medicare hasn't been paying for pallidotomies yet for focus ultrasound, so we haven't been doing them yet. But we do a lot for central tremor and occasionally for tremor dominant Parkinson's. Now, in the last few minutes that I have, I'll talk about stem cells. And I just want to say we did fetal cell transplants many years ago and learned a lot. It helped some people, but caused some problems. Um, we've done surgeries, implanted different types of cells, retinal pigment epithelial cells, porcine cells, pig cells, and now we're doing stem cell trials. So I want to get there as soon as I can. One of the things we learned from fetal cells was that they can survive and they make dopamine and they can improve symptoms, but only the dopa responsive symptoms again. And they can, in the fetal cells, cause dyskinesia is unrelated to levodopa called runaway dyskinesias. And most of those people require deep brain stimulation to control them. So we know that this is likely caused by serotonergic cells being transplanted, and that they accumulated in what we call hotspots in certain regions where they're making too much. And actually, the transplanted cells eventually got Lewy antibodies as well. So the Parkinson's brain kind of imposed Parkinson pathology onto the transplanted cells. It takes about a decade to occur, but it does happen. So now we're using stem cells, and there are different sources of stem cells. So there's what's called embryonic stem cells. They come from uh, basically a fertilized egg, an embryo, and they're converted to immortalized stem cells. Now, there are certain lines that have been approved by the NIH and FDA, and those can be used and turned into dopamine cells before transplantation. Or there's cells called iPSCs. Those are inducible pluripotent stem cells, and they can be derived from skin biopsies, from fat, even from the blood. They can be differentiated in a dish into dopamine cells, and so you can avoid those serotonergic cells. And then some people think they might even be secreting some growth factors that may help the other cells survive, though that's pure speculation. We have better delivery systems now, and one of the things that I like stem cells for is that we can use it to study why people get Parkinson's and individualize that by looking at your own stem cells. So there are three trials that are ongoing now. So the Blue Rock trial, we're participating in that. It's an embryonic stem cell line that's very well characterized. I'll show you the data in a minute. From the first 15 people that were done open label. So the trial that we're doing is a phase 3 trial, and so there's a blinded placebo group or sham surgery group. Um, and we're doing immune suppression for a year. So the stem cell lines are grown up. They've been well characterized. They're shipped to the site, frozen. They wake it up, and then they can implant it surgically. We do a year of immunosuppression so you don't reject it. And this is learned from the fetal cell transplants. Um, and then we're followed for 2 years intensely because the dyskinesias that were found in the fetal cells happened in the second year. And so these are the results from about 15 people, the low dose and high dose. And you can see that the off times improved by about 50% over 18 months, and on time without dyskinesias or disabling dyskinesias improved. So it had some definite benefits. They have not seen the runaway dyskinesias at all, which is very encouraging. And they did PET scans, and these are all the different patients, and you can see that the PET scans you may or may not be able to see, or you can trust me that it restores the red is the dopamine cells, and it can improve it. You can see here's a good case where it's depleted here, and you can see that it looks much more like a normal scan after 18 months. So they're still living, they're able to make dopamine. So the three trials, the phase 3 trial, the Blue Rock, which is the furthest along, we started enrolling people now, and people are so we're well along. The Aspen trial, I don't know all the details because we're not a site, but what they're doing is doing a skin biopsy, growing up your own stem cells and implanting them. And the great part about that is you don't need immunosuppression because it's your own cells. The problem may be that growing them up, they're all different, and the safety issues have to be addressed for every time you do it, as opposed to when you have one source, you know so much about how those cells are going to respond. So how well this is going to work is still up in the air. They did a very small open label trial, 1, 2. They presented some. It hasn't been published yet, but it's encouraging. And then there's a Japanese group. It's actually approved in Japan, even without a placebo-controlled trial, just on about 7 patients. But they're using an iPS cell line, one cell line that's been grown up. It's not embryonic in source, but it requires immunosuppression. depression as well. And there's a few sites there. It's a phase 1 open label as well. So a lot's coming along, and it's an exciting time. And I hope I left enough time for questions. I'm
Thank
gonna.
you for an amazing talk. Yes, we'll leave a few minutes for questions now. So if you have something you'd like to ask Dr. Bronstein, please raise your hand and then I'll call on you and you can unmute yourself. Does everyone know how to? And the raise your hand function is like under the React. Or Liz, do you have a question? I saw you turn on your camera.
Yeah, I'm assuming there are places in Boston that do the DBS surgery. Am I
Oh
correct?
yeah. So Mass General does it. I'm trying to think where else. I'm sure Brigham and Wims is doing it. The Harvard groups are doing it for sure. I'm trying to think. Who else? BU does it as well. Boston University does it as well. So you want to go to a major center that you want an experienced surgeon. When we've looked, there's been a couple of studies looking at DBS failures when people did poorly, and there were three things. They come in thirds. So poor patient selection, somebody who's got disabilities that you don't expect to respond to it, but they did it anyway. So poor patient selection, poor placement of the electrode. The surgeons, we do a number of redos here, and that's when they're put in the wrong place. The surgeon isn't as skilled as all the surgeons are. And then programming, the skill of the programmer. So it's easy to program a well-placed electrode, but if it's off a little bit, that takes a very skilled programmer to be able to get around it.
And do each of these institutions have statistics on that?
So that's an issue. The answer is they keep their own statistics. So when we went into that trial, the first trial, is the largest trial. We did over 150 patients. Actually, it was about 300 by the end, nationwide. Bef Before the trial, everybody was saying there was about a 2% infection rate. When somebody else was keeping score, it was 8%. One of my colleagues said, he was a golfer. I'm not a golfer, but he's a golfer, and he says, if I keep my own scorecard, I do much better than when somebody else does it. So they use internal statistics. It's hard. You hope they keep good statistics and ask them. You can ask them for it, and hopefully they've kept good records. But it's not mandated. There's no control over that in any surgery, to be really honest. So you want to go for a quality center that's been doing it for quite a while, and that usually the people with a lot of complications are known, and people stay away.
Thank you.
Thank you, Liz, for your question. Does anyone else have any questions? We have time for one more.
Very shy group. Usually have a lot of questions.
Oh,
Uh,
Larissa, go ahead.
This is kind of a broad question, but I was just wondering, like, what do you think are the benefits for like in terms of like treating Parkinson's with like stem cell therapy versus like maybe just using like drug targeted like medication?
Yeah, that's a really good question. So, in my mind, the best we're going to do for stem cells is as good as DBS without without having hardware. So, the hardware um, is okay, but it's better not to have it. They can get infected, people feel it pulls on them a little bit, requires different stimulation. So, we're hoping they treat the same symptoms. They treat the dopa responsive symptoms. So the advantages over DBS are going to be lack of hardware. You won't need to program, etc. The advantage of medications over stem cells is you have control over it. And that's the problem you have in the concern with stem cells. We did fetal cells, it was over 20 years ago. And it's taken that long to get here because you put them in and you hope they do the right thing. You hope they know what to release and how much to release. But once it happens, there's nothing we can do about it other than do another surgery to either make a lesion or put in a DBS electrode. So right now, we really don't know the benefits over medicine. It's still experimental. Um, so that's why even in the stem cell trials, it's people that are a little bit more advanced because they have basically less to lose in some ways. You know, people are very early in the disease or have mild disease. They can do really well with medication. So you want to wait till we know more about the results of the stem cell trials before you want to jump into it.
And creating a lesion is irreversible, right?
Correct.
Yeah.
I will tell you though, you know, we did a lot of pallidotomies before DBS, and they can be quite effective. You have to do them staged, so you do one side, you have to wait a year to do the other side to complications. But there are nice things about lesions too. You don't have to worry about infections and changing batteries and wires pulling and that sort of thing. But it is permanent. So there are risks.
Yeah.
All right, thank you. We'll conclude the Q&A session from here and move on into our second speaker. Thank you, Dr. Bronstein, again for your time.
My pleasure. Thank you.
So our next speaker is Wendy and Wendy Wang. Wendy Wang is a neuroscience PhD candidate in Dr. Madeline Hackney's neurokinesiology lab at Emory University. And in her talk, she will be covering physical rehab interventions for Parkinson's care. And so I'll let Wendy take it from here.
Thanks so much for inviting me. And my name is Wendy, like the introduction. So I'm just going to jump right into it. So after we've learned about some of the more invasive, effective therapies of Parkinson's, I would like to walk you all through exercise as a form of therapy. Specifically, our lab focuses on adapted Argentine Tango as a form of therapy for Parkinson's, targeting people's gait deficits in Parkinson's specifically. So exercise is a well-established form of therapy. Is supplementary to medication, which a lot of people with Parkinson are prescribed with carbidopa, levodopa. So even just in healthy older adults, regular exercise is good for you. So especially the routine regular exercise is a very cost-effective way to promote healthy aging. And especially for people with Parkinson's, they have to tackle this additional PD aspect in addition to regular aging. And exercise in PD specifically, including strength training, cardio, and dance, which I'll dig deeper into in a little bit, help with disease management in addition to medication. So a lot of people are familiar with when you take medication, sometimes you experience off time or medication-related complications such as dyskinesia. So exercise as a form of therapy can often help when medications sometimes fall short. So going a little deeper into how specifically exercise intervene and help with PD symptoms. So a lot of times exercise help you curb your motor symptoms and functional mobility. So a lot of times people with Parkinson's experience difficulties with activities of daily living, and that can come in during eating, when using the bathroom, when you're rolling around in bed, or you're trying to dress yourself, like buttoning a shirt, or just taking a shower. So a lot of times people struggle with that, and exercise specifically can help you reduce the severity of your motor symptoms and also help you practice some of the movements that are often used in these activities of daily living, and therefore improve your functional mobility. And also, my lab has done research about how partner dancing aerobic exercise can help improve your medication efficacy. So people with Parkinson's are very familiar with off time, but for those who are not so familiar, so off time is often when you feel like your medication that you usually take doesn't work as well as they usually do. So it's like wearing off, and you are experiencing some of the more obvious symptoms, like motor symptoms, like tremor. So a lot of times exercise, routine exercise help you improve your medication efficacy by reducing the duration of your off time. So this is research that we've published in our lab, actually. And in addition, a lot of exercise can actually help you with your mental flexibility as well as your memory. So a lot of times when we are navigating our daily lives, mental flexibility comes into play when we are not even consciously realizing. So for example, when you are trying to talk to a person while walking with a person, or when you are trying to maybe just double tasking, like dual tasking. So a lot of times that requires you to shift your attention between tasks. So that requires mental flexibility. So exercise can help your mental flexibility and also with your short-term memory. So when it comes to maybe trying to remember somebody's phone number when they just said it to you, like working memory like that exercise, especially the exercise that is cognitively engaging, such as dance, can help improve your memory. And also, last but not the least, exercise can definitely help improve your mental health. So one aspect of Parkinson's, I feel like a lot of people sometimes not put as much focus on is mental health of people with PD. So a lot of people with Parkinson's experience anxiety and depression, and that is due to a variety of reasons. Some directly related to Parkinson, but also some just due to Parkinson motor symptoms leading to less social time with their loved ones and going outside. So exercise is a great opportunity to get people on their feet and also socialize with a lot of other people and also introduce to people, other people with PD and form a community where they can support each other. So specifically, I would like to dig a little deeper into dance as a form of therapy for Parkinson's. So right here is actually a picture of my PI, Dr. Hackney, who runs our lab, and she was a professional dancer for over 10 years. And dance specifically involves external cueing with specific movement strategies that challenges balance, flexibility, and strength. So this is a one-sentence summary takeaway of how dance would help people with Parkinson that struggles with walking issues, balance, and so on and so forth. So Tango specifically may be superior in improving mobility and motor symptoms of PD. So what makes Tango, partner Tango, stand out among all of the other forms of dance? Because we have foxtrot, we have ballroom dancing, or we have tap dancing. There are so many forms of dancing, but what makes Tango maybe better than other dances at improving mobility and motor symptoms in PD is that, first of all, Tango, like many other dances, it employs rhythmic cueing strategies. So often when we dance, we play music in the background. We do not just dance to dead silence, right? So those rhythmic cues that happen, that is commonly found in music, actually serve as a really crucial thing to help guide your movement. So this kind of external cueing strategy is already widely employed in a lot of rehabilitation tools and technologies. So I believe I've seen technologies that you can wear in your shoes that will vibrate when a patient with Parkinson's experience freezing of gait, when they feel like their foot is stuck to the floor and they are unable to move their feet. So a lot of times external cue can help you end that freezing episode really quickly. So also, Tango employs movement strategies that improve weight transfer. So a lot of times in Tango, as you can probably see in this GIF with Obama dancing Tango, a lot of these dance have really exaggerated movement, and a lot of times it kind of demands you to shift your center of balance off center compared to when you're just standing straight. So this kind of practice shifting your weight back and forth with a partner, so with somebody that is there to help you to keep your balance, encourage you to practice this weight transfer, and therefore with practice, you might feel a little bit more comfortable and therefore get better with challenging your center of balance a little bit. So furthermore, this is tied into the weight transfer. This Tango challenges your balance ability. So often people with Parkinson's, they already struggle with a lot of gait issues and balance issues, and maybe on their own, even with an assistive device, they are reluctant to really try to perform exercise that requires them to extend their movement range, like bigger movement range. But when we are working in Tango, because it's a partner dance, participants in our lab are often working with a student that is trained in fall prevention. So they're there to help people to really push themselves to like a place where they would otherwise not be so comfortable with. And by challenging their balance ability with more practice, this is helps a lot of people to have better balance when they're just standing and walking on a day-to-day basis. And also when you're dancing tango, it encourages great posture. So this is actually not just with people with PD, because even with a lot of young people, because we're in front of the desk, we find ourselves hunching over with our necks forward and head really zooming into our screen, and our spines really curved, and that is not good. So when you're dancing tango, your instruction is to bring your shoulder really backward and drop it, and imagine your head is sitting securely above your hips. Like I always imagine you are like a little Christmas ornament with a little string on top of your head to encourage your good posture. And this kind of help counter a lot of people's posture instabilities with Parkinson, because a lot of times in people with PD, you find them leaning forward, and really when they're walking, instead of like a healthy gait, heel to toe, they often just land on their tippy toe. And that is not a great way to walk. So Tango kind of bring your conscious attention to fixing your posture as well. And also, because of the wide variety of tango dancing movements that is involved, it trains your joint mobility and muscle power. Because a lot of times, tango, there are smooth weight shifting, but there are also very sharp movements, such as like snapping your head, change to one direction really quickly and make the movement sharp. So that requires great muscle control. So by practicing those kind of movements, it will improve your joint mobility as well as muscle power. And more importantly, I would argue, so all of these together, Tango is not an independent project. It is often done in a large group of people. At least you have your partner right in front of you. So this is very much a socially engaging dance, and it is very well received among our participants. And because of the music, and you're engaging with people, and often when you are dancing with your partner, because you are so close in physical proximity, you can't just stare at them and be silent for the whole 1 hour. That encourages conversation, so it helps people, give people an opportunity to connect with each other. So the social element of tango makes it very enjoyable for not only our participants, but also our staff. So then I want to get into some potential mechanism of why tango is an effective form of therapy for Parkinson. So even though it is very well established by many researchers that tango, along with many other forms of partner dancing, is a great way to tackle gait instability and gait deficits in PD, but the potential mechanism is not very clear. But there are some theories out there. So first, because I'm a neuroscience student, I'm going to start with some pathways that involves like neurocircuitries and movement. So As we might be familiar with, PD ultimately is your basal ganglia, which is a motor center in your brain. It is not functioning well. So, with the external cues involved in Tango, such as the visual cue that you have with somebody demonstrating the dance, or tactile cues that when you experience when you're holding the arms of your dance partner, or the musical cues, like I mentioned before, the rhythmic cues and the beat. So all of these external cues can bypass the impaired basal ganglia and often activate some alternative pathways that help you move your body the way that you intend to. So one of such circuit is, for example, a cerebello-thalamocortical circuit. So it instead bypasses the diseased basal ganglia, and using external cue, it can often serve as compensatory pathway for people to really get their movement down without really going through the basal ganglia. So another potential mechanism is focusing conscious attention to your steps. So by focusing conscious attention to stepping and with practice, a lot of times walking with practice will become more automatic. So this comes with healthy aging as well. So just with aging, a lot of times the tasks that we used to do more automatically without conscious thoughts, like walking and like dual tasking, maybe it may require a little bit more conscious cognitive effort. So this is especially the case in people with PD. So hoping that by bringing attention to making big, good steps with good balance, with the practice, walking, our hope is that Tango is by bringing attention to stepping, helping people to practice stepping so that eventually their walk will become a lot more automatic than before. So also Tango, like I mentioned before, it is a lot of multitasking in a Tango session. And also within a Tango, there are a lot of task-specific training. So we give you very specific movement targets. So such as backward walking, turning to specific directions, or pausing in the middle and then repeating the movement initiation over and over again over a dance practice. So all of these things are a lot of our struggle, are challenges for people with Parkinson's, especially such as the pauses in the middle of a movement and the movement initiation. A lot of people that struggle with freezing of gait, which a lot of times happen when you try to, you stop walking and then you try to walk again, or when you simply just crossing through a doorstep. So that becomes an issue. So by practicing these kind of specific tasks that you see in activities of daily living, Tango is a great way to help you improve your functional mobility, like I mentioned before. And also simultaneously, Tango involves executing dance steps, and you're navigating the dance floor with a lot of people on it. You're trying to not bump into each other. And also at the same time, ideally, you are listening to the music, trying to keep up with the beat. And continuously, you're trying to plan your next step if you are the leader of the duo, or if you are the follower of the duo, you're trying to interpret the leader's next movement signal by this tactile cue, and also seeing how visually their foot is moving. So all of these happen at the same time. So with practice, people will definitely get more familiar with Tango, but also this is a great practice for multitasking. And thus this ties into previously I mentioned the cognitive benefits of Tango. So this is a great way to practice your mental flexibility. So next, I would like to pitch some of our ongoing studies in the Hackney lab. We are located at the Executive Park complex near Emory, right across the street from the Children's Hospital. So I have put Jill Bishop, so she is our coordinator. I've put her phone number as well as email on the screen. So anybody who's on the call that is interested in participating, who have Parkinson's or who are caregiver of people with Parkinson's. We have 3 studies that we're actively recruiting right now. Or if you're a student and want to get involved with our lab with pre-med student shadowing, getting some clinical hours, or just volunteering over the summer, we would greatly appreciate any volunteers. We're coming fall semester, join our lab to do a research class. So first highlight is a 12-month study aiming at people with Parkinson's. And as long as you can walk for over 10 feet at a time with or without assistive device, you are eligible. So with highlight, we're mainly focusing on 2 types of aerobic exercises. So we have the Tango partner dance and we have the aerobic walk. So for both types of exercise, we offer them at moderate frequency versus high frequency. So we're trying to examine how the frequency of the exercise and as well as the format of exercise would impact people with PD's ability to control their movement timing, as well as their motor cognitive abilities. And also we have another shorter study in our lab called Zesty. So Zesty is actually the name of the robot developed in our lab. So it is also facing towards people with Parkinson's. So we have 1 brief over the phone visit and 1 in-person visit. And this study is aiming to use a robot-guided interactive motor and cognitive exercise to help people enhance their performance as well as motivation for exercise. So this robot is not there to be your dance partner per se, but it does provide you with really flexible target to help you exercise at home. And also we are testing the robot to try to give you better feedback according to your exercise form. So right now we're just recruiting for Zesty for 2 visits. And upcoming in July, we are planning on starting a 3-week exercise class program with the Zesty robot. So more to come in July, but right now it's just visit commitment. And also, besides facing people with Parkinson's, we also have something for the caregiver of people with Parkinson's, specifically those who experience dementia. So the DREAM study is facing to the caregiver of people with dementia, such as Lewy body dementia, Alzheimer's, or PD patients with dementia symptoms. So this is 8 virtual meetings over 8 weeks, so 1 virtual meeting per week. And we are handing out materials to for the caregiver to read to help them troubleshoot their caregiving day-to-day life, and also hoping to offer some strategy to navigating their own life as caregiver and also some of their caregiving approaches. So this is very much a free form like discussion, and a lot of times we learn a lot from the caregivers because we say that clinicians work frontlines with diseases like Parkinson, but more often than not, caregivers know a lot more than any clinician or nurse about the specific participant, the specific person than anybody else. So we really value any input that caregiver would offer us. So that is from me, and I believe next will be Q&A. So I'm just going to put, I have a demonstration for dance, but I think I might be running out of time, so I'm going to skip it. But fun fact, I think Jerry, I saw you on the call. Jerry is one of our participants, and he participated in our dance performance with my PI, Dr. Hackney, along with our staff, students, and participants. And it was great performance. So unfortunately, I think I'm running out of time. I'm just going to, put my email contact and also my colleague Ali, who's also a neuroscience student, as well as once again Joe Bishop, our clinical coordinator, her phone as well as email. So if there are any questions, inquiries, or interest in participating or helping out, feel free to reach out to us. All right, thank you so much.
Yeah, thank you, Wendy, for the great talk. Yes, we will now open it up to Q&A. So if you have a question, feel free to just raise your hand or unmute yourself. and ask away. Andy, go ahead. Let me ask you. Are you able to unmute yourself, Andy? Let me see.
Oh, sorry. Can you hear me now?
Yes, can hear you now.
Wendy, thank you. Do you have any data on Tai Chi and ping pong and boxing and other forms of exercise versus dance?
So our lab just focused on dance as a form of therapy, but Tai Chi and ping pong, I would say, are very effective because mostly I would say what makes dance as well as a lot of other forms of exercise therapy helpful for Parkinson's specifically is that, first of all, it is both physically and cognitively engaging. And second, it helps you practice a lot of the movements that you might encounter trouble with in Parkinson's, such as like big extended movement and movements that challenge your balance and movement that encourages contralateral movement. So moving your right hand with your left leg and vice versa, for example. So I would say I see all of those characteristics with Tai Chi as well as ping pong, especially ping pong is very quick. It requires a high focus. So I think as I'm doing research, a lot of other people have done research in Tai Chi and Ping Pong, and those are all amazing exercises for Parkinson's. And even just like, even if you are, for example, not interested in any of those exercises for dancing, just regular routine exercise, trying to get out, stay active is helpful. So I would say the more the merrier, but definitely, to whatever that suits your hobbies and lifestyle. So
Thank you.
Yes, Liz, go ahead.
Does anyone know if there's a Parkinson's Tango program in the Boston area, an in-person program? I know there's a Tango Center in Somerville, but I don't know if they offer classes for people with PD.
I'm not sure, but I can definitely ask my PI, Dr. Hackney, and we are a big advocate for pushing tango as a form of therapy for because it's already recognized by I think the Society of Occupational Therapists, American Society of Occupational Therapists. It's already recognized as a form of therapy by like the authority. So uh, in fact, we've had occupational therapist students who join our lab trying to learn this form of therapy and then use it in her own practice in the future. So if there are no current tango therapy available in Boston area, I'm sure my PI, Dr. Hackney, would love to connect and then see if we can do something about it. Yeah. Want to make that happen.
I'm sure we could do a tango session at one of the ping pong Parkinson practices as well.
Oh, that'd be great because we actually just did an outreach event last week at residents living home, and all of the folks loved it. We had so much fun.
Yeah.
Thank you.
Annie, did you have another question, or is this just okay? Okay, perfect. Any more questions? Okay. If not, then we can move into our third speaker. Thank you, Wendy, again for taking the time to speak about tango. It's a very interesting topic, and I learned a lot. I hope everyone else did too. And
Yeah, absolutely. Thank you.
Now we'll move into our third speaker, Dr. Albert Hung. Dr. Albert Hung is the director of the Mass General Hospital Parkinson's Disease Center of Excellence, and he is assistant professor of neurology at Harvard Medical School. And in his talk, he will be covering medical treatments for motor symptoms of Parkinson's. And I'll let Dr. Hung take it from here.
Thanks very much, Stephanie. Let me just set up here. Are you seeing my slides, or are you seeing the presenter view?
Presenter view.
Okay. How about now?
Slides.
Okay, great. All right. Well, thanks again for the invitation to meet with all of you. I was asked to talk about medical treatments for Parkinson's disease. I know in the sessions today, you've already heard from Dr. Bronstein about surgical options, and you just heard a very good discussion about the importance of exercise and specifically dancing for Parkinson's. Here we're going to talk a little bit about some of the medicines. So as we think about Parkinson's, I think our understanding of Parkinson's now has taken some form so that we know that for different people, there's different factors that lead to the development of Parkinson's. For some people, a minority of people, there's a genetic component. There's also environmental factors that kind of conspire to cause changes in a protein called alpha-synuclein. These alpha-synuclein aggregates then form in Lewy bodies in the brain, which cause the loss of dopamine activity, dysfunction of the connections between neurons, what we call synapses, and then all of that culminates into what clinically we call Parkinson's disease. What we understand now about Parkinson's is really based largely on pathology. So up until recently, in order to make a definitive diagnosis of Parkinson's, we really needed to do pathology. You needed to look at the brain. And obviously, this wasn't something that we would do clinically. When you look at the brain of somebody with Parkinson's disease, there's loss of dopamine producing neurons in a part of the brain called the substantia nigra. You can see that on the slides on the right-hand side. If you take a cross-section through the midbrain of somebody who does not have Parkinson's, you see these areas of pigmented neurons that we refer to as the substantia nigra or black substance. And in people who have Parkinson's, you lose those dopamine neurons, and as a result, you lose those pigmented areas as you see on the right. The biochemical consequence of that is that you have less dopamine production in the brain. And when you look under a microscope at these areas, you see Lewy bodies, where you see abnormal protein aggregates in the nerve cells of the affected brain. And this is the pathologic hallmark of Parkinson's disease. And what we know now about these Lewy bodies is that the primary component of those is this protein called alpha-synuclein. So what we also understand about Parkinson's is that by the time we make a clinical diagnosis of PD, people are already well along in the disease process. So we recognize there are early premotor symptoms of Parkinson's, including REM sleep behavior disorder when people act out their dreams, or hyposmia when people lose their sense of smell. And these are features that can occur years or even a decade or more before a person develops their first tremor, stiffness, or slowness. And so as we think about treating Parkinson's, we have to think about how do we manage the symptoms that cause the most functional limitation, but we also have to think about how we're going to intervene on the treatment of Parkinson's even before those motor symptoms develop. So I think when we think about Parkinson's medications, it's really important to think about what the goals are of particular treatments. If we could envision a neuroprotective treatment, this would be something that taking this medicine would protect the brain from further damage. It would slow down loss of those dopamine neurons and slow disease progression. Now, this is sort of the holy grail of Parkinson's research. There's been a lot of work going on for decades, but at this point, the best thing you can do to slow down your Parkinson's is what you heard from Wendy, which is to exercise. We're going to spend most of the discussion today thinking about symptomatic treatments because there are many very good treatments to reduce the symptoms of Parkinson's, the majority of which work on helping the brain increase the level of dopamine. And then you could think about certain types of medications or treatments as being neurorestorative. These are treatments that would replace degenerating dopamine neurons or reverse neurodegeneration. And you heard a little bit about that from Dr. Bronstein when he talked about cell replacement. This is a list of some of the currently available medications for Parkinson's, and you probably recognize some of these from the medication list that you're taking now. And you might ask the question, well, if there are so many different medicines available, why do we need more medicines? The first is something I already alluded to, which is that none of those medicines slow down the progression of Parkinson's. Another limitation is that the medicines that we have oftentimes cause side effects or may not work well enough or last long enough. And we'll talk more about that in just a bit. Another main issue is that many people with Parkinson's, in addition to their motor symptoms, experience non-motor symptoms. And these are not necessarily ones that respond as well to treatments, and certainly don't respond that well to dopamine medicines. Also, when people are experiencing problems with gait and balance, that does not respond as well to higher doses of medication. And as a result, that's the reason why interventions like physical therapy and dance therapy are so important. There are a number of principles to think about when we're trying to optimize the use of medicines to treat Parkinson's symptoms. Again, the first one is that there's no proven disease-modifying treatments. Another important principle is that symptomatic treatments can be very effective in reducing motor disability and improving quality of life. But because they are symptomatic, what should guide the way we adjust the medicine is the impact of those symptoms on a person's activity and lifestyle. And then another important principle is that optimal treatment of motor symptoms, especially in more advanced Parkinson's, requires you to balance the benefits and the side effects. It's not always better to take more medicine, and it's important to think about what the goal is of taking the medicine and how you're trying to balance the benefits of those medicines with some of the side effects that medicines can cause. So, as many of you know, the best medicine to treat Parkinson's symptoms is a medicine called levodopa. Levodopa is what our brain normally makes, and it's the direct precursor to dopamine. So you can see this in this picture on the right. L-dopa is converted by one enzyme called dopa decarboxylase into dopamine. It's the oldest medicine for Parkinson's symptoms, but it's still the most effective medicine for Parkinson's symptoms. If you were to take levodopa by itself, it would make everybody feel sick, feel nauseous. And so it's paired with another medicine called carbidopa. And this combination, carbidopa-levodopa, is what many people refer to as Sinemet. This combination medicine is now available in a variety of different formulations. Most people start with an oral medicine, but it's also available in an inhaled form and a number of other more advanced options that we'll talk about briefly at the end. The other way you can treat a dopamine deficiency is by using medicines that substitute for dopamine, what we call dopamine agonists. And there's a number of different options that are available that work in this class. This bypasses the need for the brain to make dopamine by binding directly to the dopamine receptors. The main limitations of these dopamine agonists is that they can cause a variety of side effects, including nausea, daytime sleepiness, leg swelling, and confusion. And the main side effect that's kind of led people to go away from the use of this medicine is that in some patients, it can cause significant issues with impulse control, including gambling, hypersexuality, binge eating, and compulsive buying. And these impulse control issues can be particularly troublesome and difficult to treat. So the way that we typically treat early Parkinson's now is kind of summarized in this practice guideline from the American Academy of Neurology. For most people, levodopa is the preferred therapy, and usually in the immediate release formulation, which is more bioavailable and more effective. Dopamine agonists may still be an option for some people, but if a dopamine agonist is used, it's really important to monitor for side effects, including those issues with impulse control. There's another class of medicines that we'll talk about briefly called MAO-B inhibitors. These are medicines that help your brain hold on to its own dopamine better. And so these can be an option as initial therapy for mild motor symptoms, but they're generally not as potent and not as strong as levodopa or a dopamine agonist. For many people, using levodopa and adjusting the dose can be quite effective for the first few years. But one of the challenges is that over time, people will start to find that the medicine doesn't work as well. So it may take longer for the medicine to kick in. When it does work, it may wear off more quickly. And sometimes people will develop some side effects when the medicine is at the peak of its dose, what we call dyskinesias. These are involuntary movements. The reason why people develop motor fluctuations is because levodopa has a very short half-life. when you take a dose of carbidopa levodopa and you measure the amount of levodopa in the bloodstream, the half-life is only a couple of hours. And so when you take the medicine every 4 or 5 hours or longer, you get this oscillation of the blood levels of levodopa. You get a rise when you take the dose, then when the medicine wears off, you get a dip again. And so early on in Parkinson's, your brain can accommodate that. And so you don't get wearing off, even if you take the dose a little late or if you miss a dose. But over time, when your body is more dependent on the levodopa and dopamine in the brain, you will experience these on-off fluctuations. And after if the medicine wears off, you take the next dose, it may take a little bit of time to kick in, and then you may get dyskinesias. And so the therapeutic window where the medicine is working well without dyskinesias becomes smaller and smaller. There's a number of different ways we can try to help reduce the wearing off. One of them is a class of medicines that are called COMT inhibitors, or catechol-methyltransferase inhibitors. The reason why these medicines are effective is because levodopa, when it gets into your bloodstream, gets broken down by a number of different pathways, even before it gets to the brain. One of those pathways is through dopa decarboxylase, and so that's what the carbidopa blocks. Another breakdown pathway is this COMT transferase. And so if you block that, shown here, so if you give a medication that blocks the breakdown, more levodopa gets across the blood-brain barrier, gets made into dopamine, and so the medicine lasts longer. And there's a couple of different COMT inhibitors that are listed here. There's another class of medicines that are called MAOB inhibitors. These also work to block the breakdown of levodopa and dopamine in the brain. So you can use these in addition to a COMT inhibitor or separately. And again, it can help a little bit with early Parkinson's, but it can also help to reduce the wearing off that occurs when people have had Parkinson's for a longer time. And you can see a number of those medications listed here. The one that's probably used the most often is rasagiline, which is branded as Azilect. We now have a couple of newer extended release formulations of carbidopa levodopa that have been on the market. The medicine called Rytary, which has been available for about 6 or 7 years, and a newer medicine called Crexont, which has been available for the last 1 or 2 years. This picture at the left shows the different formulations of levodopa and gives you an understanding of why wearing off occurs. The first graph with the squares, the first one with the squares is regular carbidopa levodopa, and so it wears off very quickly. If you take a controlled release or CR form of carbidopa, it doesn't peak quite as high and only lasts a little bit longer. If you add entacapone, a COMT inhibitor, because it blocks the breakdown, you get a higher peak and you get a longer tail. And this medication, Rytary, is designed to release some of the medicine quickly and some more slowly. So you get this curve where you get an initial peak, and then as it starts to wear off, without taking another dose of medicine, it can last longer. The newer version, Crexont, some of the beads are coated with a mucoadhesive polymer that sticks to the gut where it can get absorbed, and so it will give even a smoother curve than Rytary. And so these are strategies that you can use with your neurologist. If the problem is that the medicine's wearing off, there are adjustments you can make in order to try to alleviate some of the wearing off. Now, for some people, even when you take the medication on schedule, you can get a very debilitating off period where your tremor or your slowness or stiffness come back very quickly, and it takes too long for an oral medication to kick in. So there's a number of on-demand medications for off periods. One of them is an injectable medication called apomorphine or Apokin. This is a dopamine agonist where you inject it into your skin, and it can work quickly without having to go through the GI tract. There's also another medicine called Imbresia. This is an inhaled form of levodopa that's delivered like an inhaler that people use for asthma, and it gets into your lungs and gets absorbed quickly. So there's a number of different ways to try to manage the wearing off, and also a number of ways to manage the off symptoms when they occur. There's also a number of continuous delivery formulations that are now available. There's a medication that's branded as Duopa, which is delivered through a tube that goes through your skin into your intestine. And so this is hooked up to a pump, and the medication gets delivered directly through your gut. And so by doing that, you can deliver it continuously. Now, there are a couple of drawbacks to this one. One is that it's more invasive because it requires this tube. And the second is that it still requires effective GI absorption in order for it to work. So there's a newer medicine that's been on the market for about a year. It's called Vyalev. That's the way that the company AbbVie has branded it. And in this medication, it gets delivered under the skin. So you still need a pump, but it's a little less invasive because it goes under the skin rather than directly into your gut. And because it goes under the skin, there's no dependence on your GI tract. And so this is another way that is now commercially available that you can manage some of the fluctuations of Parkinson's disease. There's another medicine that is currently being reviewed by the FDA that works in a similar way to Vyalev. It is being branded, it's being marketed by Neuroderm. And so there'll be a couple of other options that come up in the future. There's also a subcutaneous delivery form of this dopamine agonist called apomorphine, and that is branded as Anapco. That was approved last year. So one of the other complications of the Parkinson's medicines is that over time, when you are taking the Parkinson's medications, you can get some involuntary movements related to the medicines. These are called dyskinesias. The dyskinesias can occur at the peak of the dose when you first take it, or some people will notice it at the end of the dose when the medicine is wearing off. And these are different than your typical tremor. These can be sort of writhing movements. Sometimes people will experience some involuntary movements of the face, the head and neck, or the mouth. They present in different ways for different people. And when dyskinesias occur, there's essentially two ways to treat it. One way is to reduce the dose of medicine, because that will reduce the dyskinesias, but that can cause your Parkinson's to be worse. The other way is to use a medicine called amantadine. And amantadine is available, again, in a couple of forms, a regular form, and it's also available in an extended release form that's branded as Gocovri. You also heard from Dr. Bronstein earlier about the effectiveness of surgical treatments, especially deep brain stimulation. And so for people who are experiencing a good response to levodopa, but are starting to experience more fluctuations and more dyskinesias, this is the situation in which referral for DBS might be a very good option. Just going to take a couple of minutes and just talk about some other symptoms. So as you all know, when we think about Parkinson's, the motor symptoms are only the beginning. And when we look at the involvement of the substantia nigra, that's only the tip of the iceberg. So many people with Parkinson's will experience non-motor symptoms, which in some cases can be as debilitating as the motor symptoms. Some of these occur very early, like depression, anxiety. I already mentioned some of the other ones, the loss of smell or the sleep disturbance, especially the REM sleep behavior disorder. There are also non-motor symptoms of Parkinson's that occur later, cognitive impairment or psychosis or problems with autonomic function. And one of the biggest challenges is that the more medicine you take, the more levodopa you take, it can actually make some of these non-motor symptoms worse. One of the non-motor symptoms that can be particularly disabling is psychosis. So sometimes people will experience some illusions when they see things, or they look at objects and they look like something different, or this can morph into hallucinations or even delusions. And so there's a few different treatments that are available if people are experiencing Parkinson's psychosis. There's one medicine called quetiapine or Seroquel, a newer medicine called pimavanserin or Nuplazid, and then there's an older medicine, but probably the most effective treatment for Parkinson's psychosis that's called clozapine. There's also a number of other medications that can be used to treat non-motor symptoms. Many of these aren't specific to Parkinson's, but we've adopted effective trials for other medical conditions for mood, anxiety, sleep, and cognitive issues. And some of these medicines can also be very effective in the context of PD. So just to summarize, there's many treatment options for the motor symptoms of Parkinson's. It's really important to think about the history, how the symptoms are affecting a person's day-to-day activity, and to work with your neurologist to optimize the treatments. Levodopa is the best medication to treat motor symptoms, the least likely to cause neuropsychiatric side effects. But you have to think about the pharmacokinetics, how long they last, how they peak, and you have to balance the benefits and the side effects. And then it's also important to recognize that the non-motor symptoms, especially in more advanced Parkinson's, you have to think about how do you treat those, and you might have to adjust the dopamine medicines in order to find the best balance. So with that, thanks for your attention. I'm happy to take any questions.
Thank you, Dr. Hung. That was very informative. I'll start off with a question. So I saw you mention impulse control disorders as a side effect of dopamine agonist. So are there any like tools or models that are currently being developed to better help like predict which patients are at highest risk and therefore could help inform if they should take levodopa versus dopamine agonists?
It's a great question. So there are some things that we know that seem to increase the risk of the impulse control issues. One is younger people are more likely to develop impulse control issues. Another one is that women, especially smaller women, lower BMI, are more likely to develop dyskinesias. And I think that in general, I think most people, most doctors are using more levodopa. Now, the reason why dopamine agonists still have an important role is because when you compare levodopa and dopamine agonists, in general, people who use more levodopa earlier are more likely to develop dyskinesias. So that could be make it a little bit tricky. And there are there's actually a new dopamine agonist that's available, that's being reviewed by the FDA that works on a different set of dopamine receptors. And the hope is that that will improve motor function with less impulse control.
Got it. And does anyone else have any questions? Larissa?
One question I had was, so like levodopa definitely is like very helpful, but also has its side effects. I was just wondering what your thoughts were on like the future in terms of, do you think it's more so like creating new medications that can kind of fix the drawbacks of levodopa, or maybe like switching to like some other new novel medication, or like what your thoughts were on that?
Yeah, I mean, I think people often ask, well, levodopa has been around for so long, why do we still use it? Levodopa will always be the best medicine for Parkinson's. And that's because levodopa is made into dopamine. So it's not a chemical substitute. There's no off-target effects. It only works where dopamine is normally made. Now, the shortcomings are because of the pharmacokinetics. So switching to this under the skin form may be an advance in that. The drawback, again, is that it's still a bit cumbersome. When you heard earlier about cell replacement, that whole idea is to replace those brain cells and make more dopamine. So the other important thing about all of that is that when we talk about dopamine and we talk about stem cells, that only treats motor symptoms, that only treats what responds to dopamine. And I think that this is something that, as we improve the way we treat motor symptoms, some of the non-motor symptoms like cognitive issues, psychosis, all of the work that's being done in cell replacement and improving levodopa, none of that is going to treat those symptoms. And so I think that there's still work to be done, but I think that it's nice to know that there's a lot of advances.
From your perspective, what type of tool would be incredibly like beneficial in moving treatment planning towards more personalized approaches and really tailoring it to each individual's demographic, genetic backgrounds?
Yeah, I mean, so there is work going on to try to figure out, well, how do I personalize this? Now, one important thing to know is that when you take everybody with Parkinson's disease, only about 10 to 15% have an identifiable genetic factor. So a lot of the research going on now is to try to find treatments that target those genetic pathways, not necessarily because they're so common, but because if we are able to study a more homogeneous group of people, we may be more likely to find effective drugs that you can then translate to the larger population. So, some of the stem cell or cell replacement therapies, people are trying to personalize them. There's going to always be a balance. All of Parkinson's is something that we're seeing more and more of. Personalized medicine is a great idea in theory, but you have to think about, is it practical? Is it going to be feasible? Is it going to take too long? So I think there's a lot of research thinking about using personalized medicine, but I think that we have a lot of tools now already, especially when it comes to the treatment of motor symptoms, that really should be guided by a person's symptoms and how they respond. And, with that, I think there's a lot of optimization that can be done.
Wow, that makes a lot of sense. All right, we have time for just like one or two more questions if anyone has any more.
I have one. Have there been any studies done on Ritari and Crexont in terms of side effects or long-lasting effectiveness, that kind of thing?
Yeah, so Ritari and Crexont are these two longer acting formulations. They're levodopa. So I think that the side effects are similar to what you see with any form of levodopa. I think it's not always a direct conversion from regular carbidopa, levodopa to Ritari or Crexont. So I think with the transition, you always have to work a little bit with the neurologist to figure out what the right dose is. If you take too much, you can get more dyskinesias, or you can get other side effects of levodopa, dyskinesias, hallucinations, low blood pressure, and the like. I think that it's going to have the same drawbacks of every formulation of carbidopa, levodopa. I think, in my mind, for people who are appropriate for surgery, I think of Ritari and Crexont as a bit of a bridge, by extending the duration of action, having less wearing off. You might be able to delay thinking about DBS for a year, 2 years, maybe longer. But I think that the same limitations that people get with regular levodopa, you can also get with some of the newer formulations.
Thank you.
All right, thank you so much, Dr. Hung, for taking your time off today to give this talk and answer these questions. And thank you to everyone for taking time today to come to the talk. It's very exciting to listen to all of these advances and also hear your questions. And we would definitely like to host more of these events in the future. If you have any feedback or any suggestions, please feel free to just email me. I'll put my email in the general chat right now. And yeah, right here. Yeah, so just feel free to shoot me an email if you have any questions or want to become more involved in Ping Pong Parkinson sessions or stay updated in these events. And I'll stop the recording here.
Thank you, Stephanie.
Of course.